let me go to SFA cases, because I think this is the main area where we use re-entry devices, where we use crossing devices. And this here would be a very typical SFA total occlusion. I mean, wire probably goes easy in because of that nose here, but distal, you have that calcium, and you can already foresee that re-entering will be very difficult here. Yeah, and so we took it down, and wire went around that plug and didn't want to re-enter. And here again, so what you can do different to other re-entry devices? You don't have to, but you can, to, as I said, to be more gentle to that area. What you would rather, typically do, you would take the wire in, try hard, and after sometimes you don't see that collaterals anymore, and the occlusion ends here already. This is a scenario which we clearly want to avoid with going reprobate very early, or change to that catheter earlier before everything is here somehow not visualized anymore precisely. So with a re-entry device, you would probably first indeed dissect down to here, take a wire down, Pioneer, or the wire for the outback, and then push that re-entry device back down to here. And sometimes in really the 6 French devices lead to a collapse already of that segment here, which is sometimes also diseased, as in this case here, as you can see here. That, I mean, I think high likelihood, if you take an outback here parallel, that it is collapsed, you will not see it anymore. So what we do with the smaller 4 French GoBack is just start earlier. We start within the occlusion. We could, in fact, start to take that needle to the calcium and then use it here as a crossing device. Although I think this is really relatively long, dense block where you, of course, you may enter the needle into the block and drill it a little bit in, but at the end, of course, you have a 4 French bulky device, which you also need to somehow get in, maybe a little difficult. We use it as a crossing more in shorter dense calcium, but not in longer dense calcium, where we also rather tend to go subintimal or around that dense calcium. And that's what we did here. And you can see here, it just, I mean, yeah, the artery is open here again, and we activated the full length of the needle already before that, and it just went very nicely around that plug, and first attempt, and wire went back in. Yeah, that was also one of our first cases. You can see here once again the C. So the C should open to the direction where you want to have the needle to, and then you just let the needle go. And if the needle is not long enough to go around the plug, you just take the needle first out and push the whole device further down until you feel a little bit of a plopping into the open artery, or just probe with a wire thereafter. Yeah, so I think this is would be a typical use of as a re-entry device. Well, not typical, because you have the chance to start more proximal.